of a specific modality, we're going to be talking about general topics and considerations and surrounding factors that would be considered in a clinical-based practice of massage therapy. Now, there is, of course, clinical massage as a standalone service or as a practiced, modality in a sense, but we'll talk loosely on what that would all kind of contain and talk about more therapeutic or more advanced type topics that surround the ideas of massage therapy in a clinical sense. So let's go ahead and first at least define what clinical massage is. So clinical massage therapy, focuses and is targeting the rehabilitation of an individual. So this can, involve a lot of processes such as, the PNF stretching we're going to talk about, such as the, considerations of pain perception, using alternative therapies as well, in addition to the types of care or treatments that they're already going to be receiving as well. So clinical massage therapy, this takes a more advanced approach into the rehab and rehabilitation and care of the client than, say, a general wellness-based massage. But they're relatively similar and have, somewhat similar goals in the end of things of and all. So, we did just briefly see in that last slide there, talked about that if someone could not gain or gain any benefit, we'd move into what's called palliative care. So what exactly is palliative care? Palliative care is a type of care provided for someone that can no longer benefit from treatment or intervention. So essentially, we're just doing pain management, making their quality of life better. Now, typically, palliative care is usually associated with end of stage life stuff, such as, hospice and things like that. But palliative care could still be for someone who is relatively healthy and is nowhere near death's door. But so palliative care, in a sense, is just pain management care in some cases. And for instance, in the realm of massage, there could be certain conditions that a client might have, usually postural structural conditions, that we would never make better, but we can help manage the pain and the suffering that they might, or discomfort, for, I guess, a better term, that they might actually encounter because of those issues. Now, we're not going to fix the problem, but we're helping to manage it. And so that is palliative in nature. So in the realm of clinical massage, you might deal with prescriptions. Now, first and foremost, what exactly is a prescription? And secondly, what a massage therapist need to understand in regards to a prescription, namely in the sense of we do not prescribe anything. So a prescription is written instructions or medications that are issued by a licensed individual who has the authority in their licensing scope of practice to prescribe the exercises, the medications, so on and so forth for treatment. So when we talk about prescriptions and massage therapy, we always talk about being mindful of our verbiage and how we communicate with clients, and that we don't want to have our suggestions be viewed as prescriptions. So there's a big difference between, offering insight of routes or avenues a client could take in furthering their healthcare, such as, well, maybe, look into potentially trying yoga or something like that, or a movement-based therapy along with doctor's permission of doing so, as opposed to you should do yoga therapy or something else, whatever, right? So by telling my client to do something, that is technically viewed as a prescription, and it can bring liability onto us. So we try not to have that type of verbiage in there. We want to be very general. We don't want to tell our clients to do things because that's not within our scope of practice. Now, of course, on the flip side, in the sense of clinical massage, if you're a clinical massage practitioner, you might find yourself working in doctors' offices, chiropractic offices, and stuff like that, physical therapy offices, and the individuals, the patients, would be prescribed certain treatments. So usually in like the chiropractic setting, typically the clients or patients are prescribed units of massage, and those units are usually about eight minutes or so. So they maybe 2 or 3 units, so they'll get like a 30-minute massage based off of that, and you'll focus on the prescribed orders of the chiropractor themselves to work on XYZ muscles and so on and so forth. So you might actually be working under certain prescription orders for your practice if you're doing clinical massage. So when dealing with clinical massage, we're always talking about the idea of pain, right? So clinical massage, as we mentioned, is to help people get better, rehabilitate them, or manage the ease and discomfort and suffering. So a little bit sidestepped from the general wellness massage of, Swedish, where it could also be to just help people relax and calm down. We're typically dealing with people who are in pain. So what exactly is pain? And let's take a look at a couple ideas of battling pain. So pain, of course, is the unpleasant sensory and emotional experience associated with potential damage. And that's a very interesting definition there, because potential damage, we could have sort of learned patterns that make us perceive pain even though there was no pain there. So for instance, like touching a hot stove when you were a child burned you, and that painful pattern, that recollection is still ingrained into your memory. And so you might accidentally brush the stove later on in your life, and then it's just that reaction hits, right? And that you feel like you just hurt yourself, but you didn't. Now it's just a very broad, crappy example, but there are instances in which, you can react or feel pain because of different types of symptoms. And so, because the former idea of pain is that it had to be associated with tissue damage, but we're finding now that we can have pain without actual physical damage or injury to tissues for various reasons. One of the things I've looked into, which is pretty interesting, is psychosomatic pain, which you could take with a grain of salt, but our mental state can essentially breed pain into the body. And the general premise of why is that, we're not necessarily capable of, really discerning emotions and feelings. And so our brain manifests these emotional issues into physical problems as a way to sort of give it substance and make us aware of things. So you might have heard of certain instances like that, and like people having emotional releases as you're working on them. That could potentially be one justification as you're working over a problem area that's been giving them a lot of pain, and that pain was caused because of the mind, the psychosomaticism that was making pain in this area because of some emotional trauma. But needless to say, we have two types of pain. We have nociceptive pain, non-nociceptive pain. And the difference between those is, well, nociceptive pain is caused by the nociceptors, as we see here, which are the painful receptors that detect nociception, which is actual pain, usually from tissue damage. And then non-nociceptive pain is just pain that, is not caused because of direct tissue damage. So continuing our theories on the pain perception and how we can deal with it. And this is more relating to the physical, actual tissue damage of pain. How can we actually use the brain and the nervous system to kind of counteract that? So while there's, still debates and loose associations with this theory, but the gait control theory of pain kind of explains how we can essentially block out painful stimuli, painful signals, painful perception. So Melzack and Wall proposed the gait control theory of pain, which explains that essentially first off, a gait, right? A gait is just a passageway from one point to another. And if we look into this picture here, we can see that, well, there are many different receptors in an area. So for instance, as I guess in this picture here, we see that someone accidentally, might have caught their thumb with a hammer here. And so we have the nociceptors here that are going to send their signals to the central nervous system, to the level of the spine, which would probably, from the thumb, might be around like C7, right? So, and now we're sending this painful signal through to the nervous system. Well, now we can see that this person is grabbing and squeezing and rubbing their thumb after they do that. And so what you're doing is, so let's just say that the painful signal, like you just hit the tip of your thumb right here. And now I'm rubbing my entire thumb and even like maybe parts of my hand. So now in this case, I am essentially activating numerous receptors, one of which, as it's showing here, is the Pacinian corpuscles, which detect deep pressure, deep touch, as well as you can affect the Meissner corpuscles and all these other various skin receptors. And so what happens now is we're activating a lot of sensory input, because pain is still a sensory input that causes a motor output. And so first, and then the second thing here is that pain travels at a very slower rate as opposed to these other faster tactile senses. And so as this pain is traveling to the gait right here, which is the nerve root, which is the dorsal root horn of the spinal segment here, then we have the various other receptors and detectors that are now going to send their signals too, but those signals travel faster. And the idea is that only so much information can be processed at that gait at one given time. So essentially, it's kind of like overloading that gait and crowding the gait and sending more signals that are not painful to the gait to essentially distract you from the pain, which is pretty instinctual. And it makes sense, right? Because if you ever stub your toe or bang your elbow on a door, what do? You rub the area, you rub and massage it and rub it, right? So that's one justification of, why maybe massage actually works for helping pain, is essentially just creating more noise than the pain itself and helping us to deal with the pain, manage the pain, and allow healing to take over so that the pain becomes a lot less. So the neural matrix of pain is that, essentially learned pain and emotional states that are then further triggered throughout time, in a sense. So reading the definition here, produced by a cerebral network called the body self neural matrix after synthesizing various inputs, including perceptions, emotional states, and past experiences. The pain may trigger by input generated from injury, inflammation, or pathology. Pain may also occur independently. So this kind of going with what we were talking about earlier, how, you sort of read and record pain from previous experiences, traumas, so on and so forth, and then they manifest themselves later in a sense of a triggered moment. So very interesting stuff. Neuroplasticity is a concept here that we see in the chapter. So neuroplasticity, to me, is like the rewiring, the reorganization of the brain itself. So creating new neural patterns, new trains of thought, in a sense. So it's sort of like retraining your brain based off of experience and what you do in your life. So it's like kind of like thinking about habits, how you can break habits, make habits, so on and so forth. It involves this idea of neuroplasticity. And massage can play a role in that because, for instance, they say someone is dealing with physical traumas, for instance, say whiplash, right? So someone, got into a car accident, a very traumatic car accident, and the body essentially codes that throughout the body, the muscular system and everything, and they'll adopt certain patterns. They might react to certain ways. So massage can help to coax out the physical, patterns that they're dealing with, which then can help realign the mental patterns that they've developed over over that as well. So very interesting stuff as we go to, I don't want to go too deep into lots of all these instances of that, but needless to say, massage therapy can really play a role with reshaping our clients' trains of thoughts, can help really reshape and restructure and help with traumatic instances and occurrences in our client's life, especially physical traumas like that. They can be very, very jarring to the body. They can adopt those patterns and then continue those patterns, and we can help with coaxing those patterns into a more beneficial instance. So the difference between nociceptive and neuropathic pain. So nociceptive pain is where we actually have the tissue damage and it's detected by a nociceptor. Neuropathic pain is caused to an actual nerve. A nerve's more specifically not designed to actually detect pain. So the easiest example is, so if I prick my arm with a sewing needle, that's going to hurt, right? I have tissue damage, whatever, painful receptors, nociceptors detected that, sent the painful signal. But everybody's probably hit their funny bone, and while your funny bone is actually the ulnar nerve as it passes through that medial epicondyle here in that little groove, the little ulnar notch there. So that nerve, the ulnar nerve, is not specifically designed to register pain in its totality. So hitting that's why you get that weird TV static feeling, right? Because it doesn't understand what pain is. That is what we could call neuropathic pain. So the differences between acute and chronic pain. So acute, the difference here is just definitions. Acute means immediate, sudden, or sharp. Then we have subacute, which should also be on the slide, but subacute is where we're just past the acute phase and whatever. Then chronic is obviously over a longer period of time. So acute pain or acute inflammation, we can also apply these to inflammation, chronic inflammation or chronic issues or all that stuff, right? So date ranges are a little weird. So let's say I sprain my ankle. The acute phase could be 1 to 3 days. If the severity of that sprain is very intense, then it could be, roughly about a week, as like the immediate major acute inflammatory processes are still there and tissue repair hasn't begun to fully set in. Then we can have the subacute phase where now tissue repair is starting to settle in and we're moving into, we're seeing reduced inflammatory markers, immediate inflammatory markers, and seeing more healing markers to help maximize tissue repair. And then chronic pain, chronic inflammation is just after so long, there's still present problems or consistent or persisting problems because of the previous injury. Then we move into the chronic stage of care and things here. So looking at pain threshold and pain tolerance, there is a difference. So the threshold is, so first off, your pain tolerance is how much pain you can tolerate. And pain threshold is the point at which your nervous system essentially perceives something as painful. So your pain threshold is always significantly lower than what your tolerance can be, right? So you can, if someone's poking you with a stick, your body recognizes that that's a painful or unpleasant experience, but you can tolerate it up to a certain point. So, just a slight difference there. So sensitization, and it's two types. So we have central and peripheral sensitization. Kind of going along with the previous few extra things we were talking about, how the neural matrix of pain and the neuroplasticity. So central sensitization is the development towards chronic pain. So when central sensitization occurs, the nervous system goes through processes called wind up, regulated. Okay, well that's not really great explanation, but central sensitization is essentially the nervous system with its, being sensitized to certain events and certain activities and certain painful perceptions. And then peripheral is that, but obviously more related to the peripheral nervous system. So that's where we talk about like the whole, painful, the perception of the stove, the hot stove thing. That would be peripheral sensitization. Central sensitization is more like emotional instances, pretty sure, loosely said. No, maybe not an expert, so you can double check on that. But interesting concepts again, still, even though I don't know how to fully explain them. I have the idea, but pain management. Now we're getting into the actual clinical massage. So pain management, of course, right, is to manage pain or, get us out of pain. So of course, as we mentioned, we can do palliative care to help manage that pain. Or we do rehab to essentially get us to a pain-free state, and that pain management can include massage therapy, medicines, all the above to help us get out of the painful state. Within clinical massage, you might see or hear about the concepts of trigger points. So trigger points are a pretty popular thing about massage, whether it's popular because you're all about it or popular because you think it's a dumb phenomenon that people believe in. And I like to be somewhere in the middle ground. So what exactly is a trigger point by the definitions that most people know it? So trigger point is a hyper-irritable point within the skeletal muscle tissue or fascia that when provoked, the trigger point will refer a sensation, or what's called a referral pattern, or a painful signal, or a painful or irritating signal towards another part of the body, distal or away from the point in which you're pressing. So as we can see here, this would be trigger points in the upper trapezius. So essentially about these X's, if I press in one of these X's and I find the hyper irritable point in the muscle, then the red is where you're most commonly going to feel the instances of that pain. So there's a couple associated terms with the trigger points, which are, jump signs, local tenderness, local twitch response, and referred pain. So referred pain is the red pattern we just talked about. A jump sign is as you work over it, the body, you reacts, like you actually feel a painful signal and you like react to it. Local twitch response is kind of like you ever just lay still and then all of a sudden your body just twitches. That's essentially what that is. So jump signs are usually synonymous with a brief unpleasant experience as you work your way over an area and perhaps provoke that trigger point. Local twitch response is where you just work over the area and the body twitches and the client didn't even notice that it might have happened. So trigger points as a therapy. Sure, the phenomenon of something about this exists to a degree, and the big debate amongst many people is that the palpable nodule, which is also in that definition, which I didn't mention because I don't like to have palpable nodule there. Sometimes there might be, but that itself isn't a proven science in that the same therapist can feel the same muscle and find the palpable nodule in two different places. And so there's, a bit of inconsistency with that. And so a lot of people also argue that, pressing on certain points in these referred sensations are just the natural phenomenons because of the way the body is structured and works. And, to not go into the deeper rabbit holes of the Facebook debates that people have about trigger points here, I still believe that there is something to the phenomenon. While it might not be 100% accurate, it's still something real. By pressing or working an area, it is affecting another area. And we can use that to our advantage, right? Where we can essentially work this area and know that it has something to do with the surrounding areas, the referred areas. And does it benefit it? Probably, most likely, right? Massages largely beneficial for what we're doing. So it can't hurt to perhaps work these areas and maybe inadvertently help other areas. So especially, we commonly find, some justification of trigger points is that, trigger points will typically develop in muscles that are stressed out, overused, stretched out, so on and so forth. And so people who have tension headaches from stress or from postural issues, it's pretty common that they have certain headache patterns that when we work these certain muscles, refers it. And so to the referral pattern is almost a consistent. And that's what I find to be more interesting. Less so than, palpable nodules and where to press, but working on certain muscles does elicit these referred sensations almost consistently with what other people are finding. So that's what I find pretty interesting about it. So you can have a love-hate for trigger points, do your research, make your own decision. Personally, I'll believe parts of it, but I also believe parts of the counter argument to them. But very interesting stuff. Needless to say, for our test in MBLEX, trigger points are still believed and taught widely in schools, so it's worthwhile to make sure you understand them and what people believe about them. Another thing I guess I'll say about trigger points too is that Travell and Simmons, Janet Travell and David Simmons, are the ones who kind of pioneered this. You can find their big red Bibles, as we like to call them, Trigger Point Manual 1 and 2 of Myofascial Pain and Dysfunction, something or whatever. Book 1 is the upper body, and well worth it while to buy, because everybody's going to want, some trigger point work and focus on the neck and shoulders. Book 2 is the lower body. Probably less purchase, right? Unless you're dealing with athletes, but always cool books to really read over and look at, regardless. So the difference between active and latent trigger points and satellite trigger points. So active trigger points are trigger points that are present in the muscle or fascia that are continually referring painful signals. So you'll know they're there. Latent trigger points, you wouldn't know that are there until you press on it or wake it up, essentially. So latent or dormant, right, is just underneath or not actively engaging in its painful signal. And so, it's not on there. And so a satellite trigger points are trigger points that develop in the areas surrounding a central or major trigger point. So for instance, like this big red dot could be the major trigger point, and then it causes these smaller dots because of that. Now, typically when dealing with trigger point therapy, you always treat the main trigger point first, and that usually gets rid of all the satellite trigger points. So don't symptom chase and just deal with the individual satellite trigger points. Essentially go for the source. But how do you find the source? Well, that's in the art of trigger point therapy. So now we're looking at fascia, and that's, to be, in all honesty, one of the major things about clinical massage. The fascia is a very amazing, crazy, complicated concept to a degree. So fascia is the connective tissue lines that permeate throughout the body, connect things in the body, and whatever, right? So fascia itself is just, it's the in-between. It just binds and connects and holds everything together. It's all over the body. Now, Tom Myers has a whole thing about the fascial lines and fascial massage and fitness and stuff like that. Really cool stuff, really interesting to look at. So we see here some of the fascial lines, some of the major fascial lines. We have the superficial front line, superficial back line. We have the deep fascial lines. We have these side lines, the side fascial lines and everything. So here's the superficial front line. Here's the superficial back line. I forget exactly what this one is called, but it's like the side line. Here's the another side line, I think. I forget what all of these are. It's been a while since I did my research, but what's really cool and interesting is that a lot of these patterns and travel and dissections of the fascia almost line up exactly with meridians. Very interesting concept. And so, you know, acupuncture along meridian lines and into the, you know, acupuncture points might just be dealing with this fascia. Because if you think about this, right, so we have, you know, superficial fascia, right? Superficial fascia is, you know, superficial, closer to the surface of the body. Deep fascia runs a lot deeper in the body, binding soul, so on and so forth. And then visceral fascia, which is associated to the organs. The body runs off of a property called tensegrity. And so that means that everything in the body is just so intimately connected that if one part of the body moves, it shifts everything else because of everything just being so connected. There's literally, like, I don't have an exact number, but I'd say like 90% of your body is probably just connective tissue, right? Connective tissue is just the fascia, your blood, the plasma in your blood is liquid connective tissue, bones are connective tissue. You know, so much in your body is connective tissue. Namely, looking at this fascia and these coverings, you know, even the connective tissue coverings that line like muscles and blood vessels and all that, it's made out of connective tissue, right? So these fascial lines are going to pass through and by organs. And so if I have, let's say, you know, an injury at the bottom of my foot, and that's pulling all that fascia into the foot, well, that stretch is gonna go all the way up through this entire line, which that line could pass by and cause any effect on organs, any effect on posture, any effect on muscles, right? And so that's where we can really start to kind of delve deep into this whole idea of clinical massage. And that's one of the beautiful things about massage and clinical massage especially, is that it's just a super sleuthing of going through the motions and trial and error. Well, what's going on? You know, sort of playing detective of, well, what factors, what structures, what knowledge can I apply in this situation to understand what exactly is happening and how I can make it better. Orthopedics. So we probably have all heard of an orthopedist, right? Orthopedics is a branch of medicine that deals with, you know, imbalances of, you know, musculoskeletal conditions. You know, they usually provide the, you know, orthopedic objects, right? Crutches, wheelchairs, braces, lifts, edges, whatever, that help to balance everything out. Compensatory patterns and a couple types of compensation patterns that exist. So a compensatory pattern is the body attempting to adjust and make do and align for what it is lacking. So essentially, a compensation pattern is your body making do with what it has. The common examples might be a leg length discrepancy. So if one leg was shorter than the other, your whole body would tilt. And I think, let me go ahead and maybe just go into a view of me. So for instance, if one leg was higher than the other, my hips would shift. My hips would have to shift to make sure both feet were level on the ground. Well, that hip shifting is going to then cause my spine to shift and then my shoulders to shift. And so we essentially have this like zigzag pattern of the body adjusting and dealing for the new pattern it must adopt. So let's go back to our slides here. So essentially, there's a lot of types of compensation patterns out there. Okay, so I remember what this is asking about. So there's two general types. We have congenital compensation patterns, and we have functional compensation patterns. Could be a different couple different names for the same phenomenon, but congenital ones are ones that are something you're born with. So like the leg length discrepancy would be congenital alone. That's something you're born with, or it happened because of a major trauma or accident or injury that cannot be changed, because there's nothing you would do, massage wise at least, to do to make that better or change it. We would be more palliative by nature. Then we have structural or functional compensation patterns, which it's your body adopting new muscle firing patterns and body positions based off of what you do for your life. So for instance, if you answered phones and you held the phone, because nowadays we have headsets or whatever, but let's say you had that phone hugged up to your shoulder and your shoulder shrugged to your ear and your head laterally tilted to the side, your body is going to adopt that pattern to facilitate that pattern better because your body requires you to do that a lot. So those are what we call functional or structural based compensation patterns. So really interesting stuff. You can find a list of compensation patterns at the Prehab exercises website. So that's actually where this picture comes from, the Prehab guys. Really cool website, really cool group of people. So make sure you go and check out their website. They got all these little compensation patterns. This is pronation distortion syndrome of the ankle, which is, the excessive pronation of the ankle itself. All right, so differentiating postural and phasic muscles. We were just talking about the compensation patterns. So these muscles we're talking about, we might want to pay a little attention to some of the surrounding factors. So postural muscles are muscles that are largely designed to maintain the positioning of our body and create that posture. So now we talked about in the muscular system the different types of fibers, type 1, type 2, type 1, largely postural in nature. They maintain contractions for longer periods of time. Then we have phasic muscles that or type 2 that are slow or fast twitch. They react and then they tire very quickly. So we have postural versus phasic. Postural muscles are going to have larger quantities of type 1 than versus type 2 muscle fibers, and then these are going to help maintain posture. So examples would be like my quads, my calves, hamstrings, larger muscles in my back, all those muscles that are helping me stand as I am now. Then phasic muscles are muscles that contract to help us to do the very finite movements. So muscles of like my shoulder and smaller muscles that help to move like my hands and fingers and the toes of my foot. Those would be largely phasic because they contract for only short periods of time before they tire out. Talking about end feel. What is end feel? So end feel is the term that explains what a joint feels like as it reaches its terminal ranges of motion. So as we said, we have the range of motion, and as we move the joint through its range of motion, we're going to stop at some point. And so what that stopping point feels like is what we talk about for end feel. So we have here a few different types of end feel. Let's go ahead and take a look. So we have hard end feel. Hard end feel is where we run into a hard tissue structure, which would be in this case bones. The easiest example would be my elbow, right? So if I try to extend my elbow or straighten my arm out as much as possible, my olecranon process meets the olecranon fossa of the humerus and then stops it. Like I cannot physically extend my elbow out any further than this without breaking the bones. So that is hard. Then we have soft tissue end feel, which is, as we see here in this picture, soft tissues are stopping or preventing the movement from occurring. So in this case, like your arm, and I'll show you on the skeletons over here, your elbow should be able to have your forearm muscles, or excuse me, forearm bones, the radius and ulna, almost lay on top of the humerus with no problems. But we have soft tissue, aka the biceps and your forearm muscles, they're stopping that maximum range of movement. So we have firm end feel, which is just normal end feel. There is springy end feel, which is, that has a little bit of a bounce, and usually can be painful. So sometimes we call, we have the firm end feel, normal end feel, and then we have pathological end feels, which is we're stopped abruptly because of or because of the pathology or restrictions present because of pathologies in that joint. And then empty end feel is that there's just nothing to essentially stop it. Empty end feel would be like the pathological end feels that, you should be able to achieve more range of motion, but because of issues or problems or pathologies, it would stop you from continuing into any further range of motion. So very interesting, to make sure we understand the types of end feels, especially in regards to us doing some range of motion assessments. So static postural assessments, how do we perform them? What are we looking for? What could they indicate? So in this case, I might have to grab my buddy here. And use him to help us understand what a postural assessment is and what we're looking for. So a static postural assessment is just that. We're looking at someone staying still and essentially trying to identify symmetry. So we use what's called a line of gravity. So a line of gravity, also known as a plumb line, could literally be a string attached to the ceiling with a weight hanging towards the floor, because that line is going to hang straight. Then we have the client stand in front of it, and we try to see if there's any imbalances. We can also use grid lines as well. So you can see we have the grids here. And what exactly are we looking for? So in this case, we can view a client looking at the anterior side of their body, the front of their body. We can have them turn around and look at the posterior side of the body, or we can look at a side profile. And again, we're trying to identify symmetry. So in this case, what are we looking for if someone is looking at us straight? If we're looking at the anterior view, make sure my eyes and ears are level. Make sure the clavicles are level. You can also look for the apex of the axilla. You can look at the bottom bony parts of the rib cage. You can look at the ASIS of the pelvis. You can look at the greater trochanters of the hips if you can. Looking at the knees, are they symmetrical? Are they caved in? You can also look at the ankles. So what exactly? And the tips of the hands as well. Are they even? So, what could you assess because of certain things, right? If my clavicles are uneven, right, I could have, so clearly that would indicate that I have something going on with the spine. There could be some scoliosis. There could be, perhaps my hips are offline. I would then check some hip landmarks to make sure that my hip landmarks are okay. I'm just going to do this here. So, hips are all, hips could be off, right? So it's all just a multitude of factors, right? So typically unevenness of the shoulders or unevenness of the hips could indicate that there's, scoliosis, the lateral curvature of the spine. It could indicate that one leg is shorter than the other. Nothing is solid without, actual physical, without diagnostic assessment, but just a quick postural assessment could identify that. So if we turn our guide to the side here, what can we look for? Well, again, we can look for the neck and the ears. Do the ears line up roughly with the shoulders? How far forward do they hang in regards to the shoulders? Is the shoulder further forward, and is the shoulder rounded in, if so? You can also look at the greater trochanter. You can look at the side of the knee as well. So in this case, if the shoulders are forward, if the neck is forward, that could indicate kyphosis, all that good stuff. Where the what about the here in the hips, we could have the PSIS. Where is the PSIS sitting in relation to the ASIS? We could definitely assess an anterior or posterior tilt, right? So if we have an anterior tilt, they could have like a kyphotic instance in the low back, or if we have an anterior tilt, we could have lordosis, stuff like that, right? So if we turn our client behind and look from the back, right, we want to look at the back of the skull, the external, the nuchal lines here. Again, shoulders. We can observe the actual spine. This is where we can definitely see if the spine is, curved. We can definitely see if the hips are even or not. So in this case, the PSIS would be what we're looking for in this case. And then the knees and the ankles as well. So, not to go into a whole deep lecture on that, but being able to do a brief postural assessment can help us understand where muscular imbalances might be, and perhaps give us an idea of what pathological conditions we might be actually encountering. So let's head on back to our slides here in a sec. I kind of closed that window. There we go. So gait cycle. What exactly is the gait cycle, and what are the different parts of the gait cycle? So the gait cycle is how we move on foot. It's the singular step, and it's measured from heel strike of one foot to the heel strike of the same foot again. So there are different phases. So one, as we see here, we have the heel strike. So this is the initial leg, and this is where heel strike, the heel hits the ground. So then we have the double stance phase, which is where, or in this case, it says flat foot. The double stance phase is where both feet are still in contact with the ground, and we're beginning to propel ourselves forward. Then we have the mid stance phase here, also known as the swing phase, where that back leg is now shifted or swinging forward and about to do a heel strike. So in this case, now we're going to have the heel strike here, and I don't know, this one's lifting a little bit different than the normal, but yes. So we're also going to push with that back foot and strike with the next the heel strike of the opposite leg. Then we'll again go into the double stance phase, then into the swing phase of the original leg to finish off with the heel strike. So yeah, all those words were kind of confusing me, but maybe I'll even do a physical demonstration. But we heel strike with the first leg, the initial leg, double stance phase, swing phase, into heel strike of the opposite foot, double stance phase, swing phase of the opposite of this original leg into the heel strike. So what exactly are we looking for, and what we could see for dysfunction? Well, first off, what are some instances that indicate a good gait pattern? So one, the hips should be in an hourglass shape as we walk, right? And we shouldn't be excessively leaning to one side or the other. The foot that is in the swing phase should be able to dorsiflex, all these things. We also want to make sure that our arms are swinging ipsilateral to the swinging leg. So for instance, if my left leg swings forward, my right arm goes forward. That's why so that way it counterbalances the locomotion of this procedure. So, trying to think about certain issues that might deal with or make movement hard or weird as well. If one leg is shorter than the other, we limp or lean excessively to one side. If we have lordosis, right, we might have to have a deeper swing phase, and that our stride will actually be a little bit shorter because we're not able to swing the leg as far forward. So it's a couple little quick instances of what you might be perceiving about gait cycle here. Hospice care is the type of care that is provided for someone who is in the end stages of life, which, there's a whole big thing about the hospice stuff. Some people, just because you're on hospice doesn't mean that you're essentially going to die. You can be taken off of hospice if you get better. But hospice care is essentially that end stage of life, prioritizing the palliative care. Dealing with hospice, usually that part in the slide is, because massage therapy can be employed in hospice locations and provide, relief massage, palliative massage. We have the stages of grief, which there's 5 stages. First is denial. So if you hear some traumatic news, you're going to deny that it ever happened. Then when the denial is over and you realize that the truth is what it is, you become angered or angry. Then you start to bargain to try to undo whatever happened, bring that person back, usually in the sense of a dead loved one. Then you become depressed that nothing happens, or that you can't, that you have to accept the reality, and then eventually you move into the final stage, which is acceptance. So there's the 5 stages of grief. But PNF stretching and muscle energy techniques, that is our big thing here that we're going to talk about. All right, so what exactly is PNF stretching and muscle energy techniques? So PNF stands for proprioceptive neuromuscular facilitation. So in this case, we're using the proprioceptive mechanisms and the muscles activation to facilitate these different processes and essentially trick muscles into doing what we want. Muscle energy techniques essentially lines up with the same thing, using the energy, force, or output produced by a muscle to cause change. So what exactly is the difference? Well, they're almost one and the same. They're essentially 2 techniques that were devised by 2 different schools at roughly about the same time, and they have a lot of similarities and a few differences. The main difference is how much effort is used. In PNF stretching, you use, they try to maximize the muscular effort or output during the contraction portion of these exercises we'll demonstrate. While muscle energy techniques utilize just a little bit of the muscle's force or output during these techniques. So let's go ahead and crack into them. There's 3 major techniques. There's a few more, but these are the main ones that I predominantly use and teach. First off is post-isometric relaxation. Then we have reciprocal inhibition, and then we have contract, relax, antagonist, contract. So the post-isometric relaxation should be pretty self-explanatory in the idea of what we're doing. So post means after. Isometric refers to an isometric contraction, which is where the muscle is contracting into resistance and the muscle's length is not changing. Then after we do an isometric contraction, we're going to relax the muscle. How does that all work? We'll show you. So reciprocal inhibition, the word reciprocal means the opposite or inverse. And so in this case, we're going to inhibit the opposite muscle, or we're going to inhibit a muscle by using the opposite muscle. Sounds confusing. I'll make it make sense in a second. And then contract, relax, antagonist, contract literally is the best. I love the crack method. As we can see, there's the acronyms there. Why? Because it combines the former 2 techniques into one solid technique. So why not have the benefit of both? But then again, why would I do one versus the other? We'll get into that. So I will go ahead and demonstrate physically here. So post-isometric relaxation, what is the steps of the procedure? First step is to place the muscle into a stretched state. So just as soon as you start feeling that stretch in the muscle, there you are. So for instance, let's take a look at Mr. Bones here. Actually, this is my skeleton. This is Dexter. I call him diarthritic Dexter because he's got all them diarthritic joints. Let's say that we were actually trying to stretch out the hamstrings, right? Our hamstrings, as we know, flex our knee and extend our hip. So if I'm trying to stretch out Dexter's hamstrings here, well, I'm going to place him into a hamstring stretch, which is to extend the knee and flex the hip. So first step of the process is to place that muscle into a stretch position. Now I'm stretching the hamstrings, and then perform an isometric contraction. So now I'm going to hold his leg in place and tell him to contract his hamstrings, which I could say just press into my hands, whatever, however you want to verb it. Make that muscle contract. And then you contract for between 5 to 10 seconds. Most of the time we say 8 seconds is right in between. And contract the muscle into an isometric contraction. And then after about 10 seconds of a contraction, tell the client to let their muscle go, stop contracting that muscle, and then you push them further into a stretch. Then you hold that stretch, hold that new position for about 45 seconds, 30 to 45 seconds, to allow the structures to reshape, namely the fascia, and then you repeat. And then it's wash, rinse, repeat after that. So that is post-isometric relaxation. And it's used very generally. It's just kind of the bread and butter of the techniques. So what exactly is reciprocal inhibition? First, reciprocal inhibition is a neurological law, Sherrington's law as it's called, that states that when a muscle receives a stimulus to contract and shorten, then its antagonistic muscles receive a stimulation to relax and lengthen out. Why? For instance, if I had my biceps and triceps, if I told my biceps to contract and then I told my triceps to contract at the same time, I would be stalled out, or the stronger muscle would win. So in this case, we're essentially tricking the brain into stretching out muscles for us. So in this case, if I'm trying to target the hamstring muscles and make those muscles lengthen out, then if I make my client contract their hip flexors and produce flexion of the hip, then it's actually going to shut those hamstrings off and I can allow it. And so in this case, I'll say, go ahead and try to bring your leg towards you, and then I will assist in that movement to stretch out the hamstrings, and then we hold again for about 45 seconds and then repeat the process. So reciprocal inhibition is really useful if, or you would use reciprocal inhibition if over PIR, the post-isometric relaxation, if there was injuries preventing the contraction of that muscle. So maybe perhaps tears, but you still want to at least get some range of motion in, so on and so forth. And then crack is the ultimate stretching technique here because it combines both techniques. So first, to me, I don't have any general consensus on which one to start over the other. Arguably, I think starting with reciprocal inhibition works fine too, because I could say, all right, so for instance, the hamstrings, all right, try to pull your leg towards you. All right, cool, that's our position. Go ahead and contract, and then I'll have them contract into that position, and then relax. And then as I tell that client to relax, I tell them to try to continue moving the body part towards them. So essentially, I'm just combining both techniques into one, doing one after the other. And that's the general procedure of the PNF stretching muscle energy techniques, right? And the purpose of them totally is to increase the resting length of the muscle tissues and muscle fascia. Very beneficial techniques, really, really awesome. I love it for my sports massage, love it just in general. I call it the massage magic because it produces greater range of motion almost instantaneously. And so it's like magic how fast it is, and it always shocks and surprises the client. And that is the end of this lecture. I know there was a lot to take in, a lot to cover, a lot of concepts, and hopefully I got most of them right there. Some of those things that I put on there and I kind of forgot about them over time. It's been a while since I did this lecture, so maybe double check my work on that. But yeah, I think I'm going to end it on that one. Definitely some really good takeaways. Make sure you understand about trigger points. Make sure you understand the PNF stretching. Make sure that you understand the ideas and concepts behind pain and pain perception. Until next time, have a great one.